Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your top free source for on-the-go board review. On this episode, per listener request, I will be discussing Pediatric Neuroradiology Congenital Brain Anomalies. This is a high-yield area on the ABR core exam, and this contains a lot of challenging words to pronounce, so I will do my best. I will make a free downloadable study guide on this topic available once this episode posts that you can download on my website, theradiologyreview.com. As a reminder, you can follow at RadRevPodcast on Instagram or Twitter, where I am currently posting on a near-daily basis tips for the physics portion of the ABR core exam. Without further ado, let's get into the questions and answers for this episode. First question: what are basic differences between anencephaly and acrania? And that is ANENcephaly. Anencephaly. What are basic differences between anencephaly and acrania? With anencephaly, one would expect to see no brain, no skull, and no scalp above the level of the eyes in a fetus. If brain is present in a nearly fully formed manner, but exposed, and perhaps lined only with a thin membrane, that is termed acrania, meaning absence of the cranium. With acrania, the cerebral hemispheres are largely present, but often still abnormal and covered only with a thin membrane. Acrania alone is often, unfortunately, lethal, and acrania can progress to anencephaly. Next question: what are basic differences between aqueductal stenosis with massive hydrocephalus, hydranencephaly, and holoprosencephaly? With aqueductal stenosis with associated massive hydrocephalus, one should be able to see a thin rim of peripheral brain tissue as well as presence of the falx. Look carefully for that peripheral rim of cortical brain tissue to tell you that the brain is present, but compressed due to the massive hydrocephalus that can be a result of aqueductal stenosis. I will talk further about holoprosencephaly on further questions, but for this question, one would expect to see a monoventricle with no falx. Holoprosencephaly results from incomplete separation of the two hemispheres. Remember the association between holoprosencephaly and Patau syndrome, which is trisomy 13, and that is spelled P-A-T-A-U. I'm hopefully saying that reasonably correct, Patau syndrome. Holoprosencephaly will often have other associated anomalies that can include facial abnormalities, renal abnormalities, and things like polydactyly. Finally, with hydranencephaly, there is some sort of insult, such as ischemia, which is often bilateral middle cerebral artery thrombosis, or infection to include things like HSV, CMV, or toxoplasmosis, that can cause supratentorial cerebral parenchymal destruction, resulting in loss of brain tissue and a residual CSF-filled membrane from ex vacuo expansion of the ventricles. The presence of the falx is expected with hydranencephaly. Hydranencephaly is the sequelae, again, of supratentorial destruction of a normally formed brain, so it is not associated with things like facial abnormalities. Be cautious that with hydranencephaly, the brainstem can bulge and mimic fused thalami, which can cause potential confusion with holoprosencephaly, which we will get into more detail on later. Next, what is porencephaly, which is sometimes called a porencephalic cyst? That is spelled P-O-R-E-N Cephaly. Porencephaly is a mild form of hydranencephaly, in which only a small portion of brain tissue has been destroyed, with a residual CSF-filled space occupying the area of insult. Remember that a porencephalic cyst does not act as a space-occupying lesion, and it should not enlarge over time. It is simply the fluid-filled remnant of what was once brain parenchyma. Next, what are some key features of Patau syndrome? Patau syndrome has an association with holoprosencephaly, polydactyly, hitchhiker thumb, and echogenic bell on ultrasound, among other findings. Remember, Patau syndrome is a chromosomal 13 trisomy. Alobar holoprosencephaly is often considered a characteristic association of trisomy 13. About 75% of neonates with Patau syndrome do not survive past 6 months. Don't confuse this with Edwards syndrome that has a chromosomal trisomy 18 association and is associated with cardiac disease, rocker bottom feet, clenched third and fourth fingers, intrauterine growth retardation, prenatal demise, and so forth. The trisomies are important for the ABR core exam. I just reviewed some key features of trisomy 13, Patau syndrome, and trisomy 18, also termed Edwards syndrome. Next question. What are some key differences between a Chiari 2 malformation and Dandy Walker? For Chiari 2, the posterior fossa is too small. Other features include things like a banana appearance of the cerebellum and lemon head configuration on a prenatal ultrasound, absent cisterna magna, ventriculomegaly, spinal dysraphism, a beak-like tectal plate, tonsillar herniation, thalamic pseudofusion, and a hypoplastic falx with cerebral interdigitations. I hope you got all of that. If you need to review this, download my study guide and read through this a few times. Whereas with Chiari 2, the posterior fossa is too small, I remember that with Dandy Walker, the posterior fossa is essentially too big, and there is cystic dilatation of the fourth ventricle. Dandy Walker has varying degrees of Vermean hypoplasia, and more than half have hydrocephalus and may have other anomalies to include polydactyly, corpus callosum dysgenesis, cardiac anomalies, and so forth. Next question. What are key features of Chiari 1 malformation? Chiari 1 malformation has tonsillar ectopia, wherein the tonsils typically lie at least 5 millimeters below the foramen magnum. Chiari 1 has a risk of hydrocephalus secondary to a ball and valve type obstruction at the foramen magnum and risk of spinal cord syrinx. Often, Chiari 1 is asymptomatic, and this may be an incidental finding on imaging. Treatment for more severe cases of Chiari 1 can include shunting and posterior fossa decompression surgery. Next, what is more common, congenital cytomegalovirus or congenital toxoplasmosis? Congenital cytomegalovirus is something like 10 times more common than congenital toxoplasmosis. One key feature that can help separate these entities on imaging is that congenital cytomegalovirus is more associated with periventricular calcifications, whereas congenital toxoplasmosis is more typical for random, scattered calcifications within the brain. Next, what are key features of Meckel-Gruber syndrome? That is Meckel-Gruber, Meckel-Gruber syndrome. Meckel-Gruber syndrome is considered a triad of 1. Renal cystic dysplasia, 2. Holoprosencephaly with potential occipital encephalocele, and 3. Polydactyly. Meckel-Gruber syndrome is an autosomal recessive disease that shares many features in common with trisomy 13 Patau syndrome, but is different. Meckel-Gruber syndrome is often fatal at birth due to renal failure and or pulmonary hypoplasia. I would remember the triad of renal cystic dysplasia, holoprosencephaly with occipital encephalocele, and polydactyly as key features of Meckel-Gruber syndrome. Next, what is rhombencephalosynapsis? That is a long word. RHOMBEN, rhombencephalosynapsis. Rhombencephalosynapsis is basically an apparently fused cerebellum on imaging with vermian agenesis. That RHOMB should cue you in to something with the cerebellum, and this has a fused-like appearance of the cerebellum with vermian agenesis. Next, what is Joubert syndrome? Hopefully I said that one right. Joubert, Joubert syndrome. Joubert syndrome is sometimes termed cerebello-oculorenal syndrome, and that is very descriptive to let you know that the cerebellum is involved, and cerebellar anomalies include congenital vermian hypoplasia or aplasia, and an abnormal-shaped fourth ventricle. Sometimes this has been termed an umbrella-shaped fourth ventricle. Renal anomalies include small dysplastic kidneys, and ocular anomalies include things like abnormal eye movements, Joubert syndrome. Next, what are key differences between alobar, semilobar, and lobar holoprosencephaly? With alobar holoprosencephaly, you would expect features that include fused thalami, a monoventricle, no interhemispheric fissure. You basically have one lobe, and no falx or corpus callosum. Semilobar holoprosencephaly has partially fused thalami, a partially formed falx, and presence of the interhemispheric fissure posteriorly with fusion of the anterior brain. Lobar holoprosencephaly has hypoplastic frontal lobes, but they do appear as separate frontal lobes. The falx in lobar holoprosencephaly extends frontally, and you typically have presence of the temporal horns of the lateral ventricles. Septo-optic dysplasia may be considered the least severe form of lobar holoprosencephaly and has things like an absent septum pellucidum, hypoplastic optic nerves, and hypoplastic olfactory bulbs, and pituitary dysfunction. Next question. What are differences between Schizencephaly and Lissencephaly? Let's start with Lissencephaly. With Lissencephaly, the brain is smooth, and you often have subcortical band heterotopia. With Schizencephaly, the brain has abnormal clefts, and those abnormal clefts are lined by gray matter, and if the clefts lined with gray matter extend to the ventricle, that is sometimes termed an open lip schizencephaly in comparison to a cleft that does not extend to the ventricle, and that would be considered a closed lip schizencephaly. Final question on this topic, at least for now. What is pachygyria polymicrogyria? And that is spelled Pachygyria, pachygyria polymicrogyria. Pachygyria polymicrogyria is a cortical malformation with features of too thick, that is pachygyria, and too numerous, polymicrogyria, gyri. Again, too thick and too numerous gyri. Pachygyria polymicrogyria has an association with cytomegalovirus and metabolic derangements including Zellweger's syndrome, Zellweger, Zellweger syndrome, which is also termed cerebrohepatorenal syndrome. And as one would expect, you have abnormalities of the cerebrum as well as the kidneys and liver with Zellweger syndrome. That is enough for now. That was a lot of spelling on my part. These are difficult words. It may be helpful to read through some of these questions and answers for review. You can find that at theradiologyreview.com. Thank you for listening to this episode. I hope this is helpful for many of you. Keep up the good work. Study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.